patient for ductus arteriosus, a therapeutic challenge. My name is Stela Karine Braun. I am a vascular surgeon at the Federal University Hospital of Franciscana University in Santa Maria, Brazil, and I don't have a conflict of interest. The article issue. Ductus arteriosus is a fetal vascular structure that connects left pulmonary artery with the heart. It causes spontaneous in more than 90% full-term born in 48 hours of life. When patency is more than 3 months, there is a genital disease. PDA, or system of ductus arteriosus, is one of the most common congenital heart defects. Incidence in full-term children is 1 case 2,000 hearts. Is more associated with preterm babies. Ratio between the sexes is 2 male case. Untreated PDA is associated with complications such as atrial fibrillation, ventricular hypertrophy with congestive heart failure, pulmonary vascular disease, inadequate physical development, infectious aneurysm, dilatation of the duct, and calcification. Many of the consequences of a PDA results from a possibility of endovascular treatment using aortic endoprothesis. 13 years old with hypertension leads to dyspnea on moderate tension with relief rest, and he presents heart murmur too. Previous transthoracic echocardiographs demonstrate persistence of ductus arteriosus, significant volumetric overload of left atrium and ventricle, and moderate aortic ectasia. When he medical assistant, a new transthoracic echograph smooth left ventricular hypertrophy, atrial fibrillation, pulmonary arterial hypertension, and a function of 50%. Cardiac catheterization was done and demonstrated mild pulmonary hypertension, presence of significant change at the level of pulmonary artery, estimated a KPS more than 2.5 liters per minute without obstructive coronary lesions. Aortic angiotomography classified the PDA as Krichenko type D, associated with the of the pulmonary artery trunk and its central branches. This is the angiotomographic combination. Here, the PDA and persistence of ductus arteriosus. 5 months of follow-up, symptoms are worsened. After evaluation by cardiac and vascular surgery teams, endovascular treatment was indicated. Because structure changes represent an increased risk from cardiopulmonary bypass. Universidade Hospital of Santa Maria is a public hospital and didn't have necessary devices for PDA treatment for percutaneous form. And patient's anatomy was challenging. Then the procedure general a retrograde puncture and insertion of 5 French introducer into the left common femoral artery. The right common femoral artery was dissected and a 5 French introducer placed. Passage of 0.35 inches hydrophilic guide pigtail catheter center of the left common femoral artery, and angiography was done. The Landerquist withdrew is passed through the right common femoral artery to the ascending aorta, followed by implantation of a zenith alpha endoprothesis. This is endoprothesis of Cook, 44 by 179 millimeters in zone 3 of the aortic arch and descending aorta. Control angiography showed the absence of leaks and PDA and patency of the left common carotid artery, left subclavian artery, brachycephalus. This is a control angiography. This is a descending aortic and free flow look at the level of the left subclavian artery. Patient had a good postoperative recovery without complications. Follow-up consultation at day 17th and 45 demonstrated a good postoperative recovery, and 4 years after the procedure, patient was asymptomatic. Control tomographic is normal, descending thoracic aorta. Proximal went close to the orifice of the left subclavian artery, enos of endolic, and PDA exclusion. Here you can see the endoprothesis, descending aorta, no more PDA. Again, endoprothesis, no more PDA. Many patients begin a diagnostic investigation after auscultation of a heart murmur on left sternal border. Others are descendantly diagnosed. Asymptomatic patients with moderate PDA may have chronic overload the left and presents with complications, atrial fibrillation, and heart failure. Our patient was asymptomatic during 44 years and then began showing exercise intolerance, thoracic echocardiography confining the atrial fibrillation, and signs of heart failure. Is determined by the options deviation and depends on size and length of PDA and difference between pulmonary and systemic vascular resistance. Hemodynamic consequences can be categorized by the degree of shunt based on the rate of pulmonary to system flow, PPKS. Small shunts, PPKS less than 1.5, the patient was asymptomatic and diagnosed incidentally. KPs between 1.5 to 2.2. The patient demonstrated intolerance to exercise and increased volumetric load of the left atrium and ventricle. Large KPKS more than 2.2, the patient demonstrates overload of the left ventricular volume and increased pulmonary arterial pressure. For PD is mental importance. X-ray may be completely normal or show enlargement pulmonary arteries. Electrocardiogram may be normal or presents sinus tachycardia, atrial fibrillation, auricular hypertrophy, enlargement of the left atrium. Echocardiography is the exam of choice. Diagnose cases and classify as silent, small, moderate, or large PDAs. Use it for assessing other disorders and looking for malformations. Magnetic resonance or computed tomographic is important tools for visualizing vascular anatomy and level of arterial calcification. Cardiac catheterization is important in all patients to evaluate pulmonary vascular resistance and the degree of ductus arteriosus. PDA can present in several shapes on angiography. Krichenko classified them into 5 groups. Type A is a ductal chronic, well-defined equation at its pulmonary ends. Type B is a large and small duct, similar aurations. Type C is a tubular duct with not constrictions. Type D is a multiplex constriction in the ducts. And type E is a longer duct, often seen in portraits. Our patient that have a type B large, small duct. Guidelines from American College of Cardiology, American Association, and Society of Cardiology suggest closure of almost all PDAs, except for small, silent ducts without audible murmurs and patients with pulmonary arterial hypertension with right to left shunts. Class 1 indications are shunt associated with volume overload in the left atrium and or ventricle, development of pulmonary arterial hypertension, and previous history of arteritis. The indication of closure of PDA with small and silent shunts are less certain. Percutaneous and surgical approach remain the 2 primary closure methods for adult PDA. Percutaneous closure is further due in patients because surgery has a easy perioperative risk due to ductal friability, calcification, and associated comorbidities such as coronary arterial disease or aortic atherosclerosis. Catheter is a procedure of choice for most babies, children, and adults with PDA. Variety of devices and techniques increases the ability to treat most patient ducts with catheter-based techniques. Success of bladder duct occlusion is 99%. Zenitial for treatment of thoracic aortic disease like aneurysm. Concerns about the use of this is patient with small femoral arteries and advanced atherosclerotic disease or with atomic variants of the aortic arch. It is a therapeutic option considering the complication and increases surgical risk. Surgery, success in managing PDA. This is treatment of choice for PDA in preterm infants in one pharmacological treatment phase. Also remains the treatment of choice for very large ducts or unusual duct anatomy. Most few intraoperative complication is bleeding. conclusion, this case demonstrates the natural history of PDA, which varies from asymptomatic to congestive heart failure, the possibility of endovascular treatment using the zenith arteriosus was wanted. This approach can be employed regardless of PDA size and is effective and safe. This is referred in my presentation, and thank you for attention.
Yeah, thank you very much, Dr. Stella Karine Braun from the University of University.